أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم والعصر إن الإنسان لفي خسر إلا الذين آمنوا وعملوا الصالحات وتواصوا بالحق وتواصوا بالصبر. In the name of Allah, beneficent and the merciful. I swear by the time, truly, humankind is in loss, except for those who have faith and do righteous actions and exhort, urge each other to the truth and patience, steadfastness.
Jazakallah. I would like to introduce our worthy speaker for today's talk, Professor Shehan Williams. He is the immediate past president of Sri Lanka College of Psychiatrists, serving as a Secretary General SAARC, Psychiatric Federation, and is the president of Lanka Alzheimer Foundation. He is also professor in psychiatry, Faculty of Medicine, University of Kelaniya, Sri Lanka. He is joining us from Sri Lanka on request of Professor Dr. Iqbal Afridi. Now, I would like to request Professor Shehan Williams for proceeding further with his presentation. Over to you, sir.
Thank you very much. Greetings again, and I'm honored to be here this morning. I also must say that some of our trainees from Sri Lanka also are joining in this session. And I'm so happy that we can all join in together to discuss this very important topic. I think it is relevant, and I'm sure many of you have different ideas and thoughts on this topic. And I hope it will help us to stimulate and also go forward and perhaps think of collaborating together in sometimes developing some of the models in terms of reaching out to the community.
Sure. Sir, we would like you to share the presentation.
Okay, so I hope you can see my presentation now.
Yes, sir.
Right. So I'm going to talk about community mental health in South Asia, the challenges as well as the opportunities that we have. Now, as you know, South Asian countries comprise 1/4 of the world's population. We know that one of the biggest populated country, India, is in the South Asian region. And we have small countries like Bhutan and Maldives with smaller population. So we have a huge challenge to meet the mental health needs of all the people in our own countries. So it's about reaching out to a vast number of people and ensuring their services, their community or mental health in the community. Now, traditionally in the West, I think they came up with this concept of treating people in asylums in the 15, 16, 1700s, and they put people in their asylums when they were mentally ill. And it was only in the 21st or the 20th century that they brought out this movement of community psychiatry and started this concept of deinstitutionalization, of having people move out of institutions back into the community. Now, if we see our parts of the world, we too have sometimes, at different times in history, have been influenced by Western concepts, and we too have developed a few but limited asylums in some of our cities. But the vast majority of our people have been in the community. Even with mental health disorders, it is the families and the communities that have supported the mental health as well as those with mental ill health. So even the disordered people, most of the time in our parts of the region, are supported by families, extended families, and communities. So the concept of community psychiatry is really not new to our parts of the world. The vast majority of South Asia is really practicing mental health and psychiatry in the community with the support of families and the communities and the religions and all that we all share together. So what is the mental health backdrop in terms of what the World Health Organization is telling us? Now, although we talk of mental health in a very broad way, World Health Organization identifies certain disorders to which we have, as psychiatrists, have to pay a lot of attention to, because it is something that needs specialist input. And the mental health gap action programs identify depression, bipolar affective disorder, schizophrenia, other psychotic disorders, dementia, intellectual and developmental disorders like autism as priority mental and neurological disorders. So those of us who are psychiatrists have to particularly focus in these areas in terms of providing our specialist input. And South Asian countries, in terms of global reports, report the highest prevalence of common mental disorders globally. Now, this is a recent systematic review and meta-regression analysis published by some authors in Pakistan, and you may see some of the names here and may recognize them. I'm not sure whether anyone who was involved in this paper is already present there in the audience. So they pulled the data in our parts of the world, and they say that any disorder, there is nearly any mental health disorder affects nearly 14.2% of the population. Among them, nearly 1/4 of the population has depression, or 26.4% is affected by depression. And alcohol abuse, 12.9%, anxiety in 25%, again, tobacco smoking in 18%, PTSD in 17%, anxiety and depression in 28%, suicidal behaviors in 6.4%, and opiates addiction in 0.8%. Similarly, we look at cannabis, generalized anxiety disorder, bipolar, less amounts, but still significant prevalence. And considering the vast population that we have a significant number of people who are affected by these problems, who need specialist input and care. Now, what is the mental health gap? When we look at the global literature, there is a lot of discussion now on what we call the mental health gap. The gap between what we are treating and the people who are untreated. So particularly in our parts of the world, 75 to 85% of people with mental disorder receive no treatment for their disorder. And this is in contrast to high-income countries where too, nearly half the population do not get the treatment they need. So those of you who are seated there, I think, and those of us who are doing psychiatry are blessed. And I think when we took up psychiatry, I think this would have been one of our main driving factors. And that is that we choose a field in medicine where we can serve the most. One of the most neglected fields where most people suffer in silence. And this is why those of you who are residents and registrars need to be happy that you have chosen the right field where you can serve the most deprived communities. And also the gap is large and there are so many people who need our help, who have not been reached and helped. So when we look at the mental health service provision, we need to also consider the expenditure for every mental health effort or service provision. We need a budget, and the governments have to give us money to reach out to the people who need mental health services. So despite there being a huge gap in the provision of mental health services, the public health expenditure overall for health itself is low, and mental health, as you know, gets stepmotherly treatment, and we don't even get 10% or 1% of the budget that is allocated for health when it comes to providing services. So we have a great challenge, and as psychiatrists, we cannot confine ourselves to just studying psychiatry, but we also have to look at developing our leadership skills to fight nationally and with administrators and government ministers to get more allocation for mental health care. So if you see, Pakistan, for instance, allocates for the total health expenditure only 3.2% of the national GDP. This is in contrast to countries like United States who allocate 16.9%, UK 10%, India slightly higher 3.5%, and I think Sri Lanka is 3.7%. Still, we are all in the same range, and the low middle income country average for health allocation is 4%. So those of us in the South Asia region have to deal with very low allocation of money for the whole health system. And therefore, we have to fight for more money for mental health, which is the most neglected priority in the world. Now, when we talk of community psychiatry and community mental health, as residents and as psychiatrists, we need to look at this whole concept of MH gap, which the WHO is promoting. So the principles of this MH gap document is to promote autonomy and independent living in the community and discourage institutionalization. So the important thing, as I said, is that in our parts of the world, whether in Pakistan or India or Sri Lanka, most people with mental illness live in the community. We have not institutionalized them, and we should not in any way try to institutionalize them even in the future. We have the advantage of working with families and communities, and we need to continue that. And the core concept of the MH gap WHO can be implemented because we can provide care in a way that respects the dignity of the person within their family, in their community, in the local situation that they are in. The care has to be culturally sensitive and appropriate. It has to take into account our religious beliefs and our close-knit families and communities. It has to be free of discrimination, whether political or otherwise, and it has to really cater to the indigenous populations that we need. So some of the Western models of care and Western philosophy and ethos of care have to be questioned when we think of community care for our people in the communities that they live in. So again, the principle further strengthens what we are already doing in our practice, where we involve the carer or the family member in the person's care. We encourage involvement in self-help or family support groups where available. And we also mobilize resources of social and community support in the local area, educational support, which is provided by our educational institute as well as religious institutions, housing and vocational support. And we try as much as possible to prevent stigma, marginalization, and discrimination for those people with mental illness in our community. Now, although WHO itself promotes mental health and has given us these documents like the mental health gap document, we have to realize that when it comes to allocating funds, interestingly, even the WHO does not allocate enough funds sometimes for mental and neurological disorders. So if you see here in the red, you see the burden of disease for mental and neurological disorders in 2004. So in all the regions, including the Southeast Asia, the burden is high, but the allocation of funds by WHO for this specific area and the specific area of mental and neurological disorders is much lower than what they should be doing. So even organizations like the World Health Organization, I dare to say, do not walk the talk, and they do not allocate enough funds for mental health. So I will just go through, I must confess my ignorance of the mental health policy of Pakistan, but we had certain policies which we put in place, which we tried to implement over the past 10 to 15 years, which has brought in a lot of rewards for our mental health service. So we, in our initial mental health policy that we developed from 2005 to 2015, we focused on a comprehensive and community-based service, which was accessible and affordable to all the people, that ensured the dignity and rights of the citizens and treated mental disorder in an efficient, holistic manner. And I think this should be our primary goal wherever we practice psychiatry in our region. Now we have developed this further, and in our mental health policy document, which is now ready, which is for 2020 to 30, we have changed it a little different in terms of the mission. And we say that it's about establishing an enabling environment for the enhancement of mental health and well-being for all through mental health promotion, illness prevention, treatment and rehabilitation, psychosocial care, and protection and promotion of human rights. So this is a more broader concept, although sometimes when you use sort of very broad concepts, we lose sight of the reality of really what we should be doing in our day-to-day practice. Because sometimes when you think of protection and promotion of human rights, then we don't think of the little things that we can do in our practice in terms of doing this, and think that governments and other organizations have to play a bigger role in this endeavor. Now, so going on to the real issues that we have to face, and for which as psychiatrists we have to give leadership, because nobody else gives this leadership in our society. We need to think of practical mental health issues that we have to address. So as psychiatrists, we are not just confined to treating mental disorders, but in the developing world, we have a greater responsibility of addressing bigger mental health issues. Now, I think we know that developed countries have hundreds or thousands of psychiatrists to meet the needs of the people. But in our countries, we have but few psychiatrists. I think, I'm not sure about the numbers. I'm told that Pakistan has around 400 or 500 psychiatrists. I may be wrong. I will give you an opportunity maybe during our discussion. I would like to clarify this point. In Sri Lanka, we have around 150 psychiatrists at the moment. When I started out, it was around 20 or 30, and we had 20 million people. And we were like 1 per million people. And now we are somewhat better. We are less than that, maybe for one psychiatrist for around 500,000 people, or maybe around 300,000 people. But still far less than what is seen in many developed countries. So we have a different responsibility than the average psychiatrist who is trained in the Western Hemisphere. We have to train ourselves to look at the different population and also develop special interests in some of these areas. We cannot have specialized, sometimes alcohol-related psychiatrists, but we may have to develop special interests while also addressing all these problems that we have to face day to day. So I have listed them. You will realize that there are other areas which I may have missed, but they are like if you take a life course, starting from children, going on to disabled person, the use of alcohol and drugs among the community, going on to the elderly population, who are also a very important population with mental health needs. We also see a lot of chronic mentally ill people on our streets who are not cared for. There are exploited workers in estates, in garment factories, in sort of busy city industrial zones, families of foreign employees, many abused women and children who all need the mental health support that we can give. We also know about the issue of suicides, deliberate self-harm. And last but not the least, the newest challenge that we have that is brought on by the newest global disaster, the pandemic, COVID-19, and the related mental health consequences. So we have to respond to all these needs. Now, when we look at psychological problems in children, we have to reach out to schools, to teachers. We have to think of developing, or we have developed special schools for the children with intellectual disability, with autism and so on. So all these are areas that have to be integrated into our community approach in developing better health in our community. Alcohol and drugs, again, a huge area that needs a lot of input. And I think, although we may be concentrating sometimes on rehabilitation centers for those with alcohol and substance dependence, and also community support centers and support groups, the main focus as psychiatrists should be on health promotion and prevention, because we all know that once people become dependent, it is very difficult. We have to put in a lot of resources to bring the person out of their dependence. So the important fact is about de-glamorizing the use of these substances and promoting better health, healthier living, and preventing our younger generation from entering into these vices which destroy their physical as well as their mental health. Now, what about the elderly population? Again, we are facing a tsunami. They call the geriatric or elderly tsunami that we are going to face, because our population over the age of 65 is rising rapidly in our parts of the world. For instance, if you look at it, 2025, we will have 154 million people over the age of 65. And by 2050, well, some of the residents here will still be practicing or maybe just practicing. You will see a population more than the population of Pakistan over the age of 65 years in South Asia. Are we ready for this tsunami? Are we ready to tackle this problem of elderly people, many of whom who will be afflicted by dementia, as well as depression, as well as other neurological disorders like Parkinson's disease, which will bring on a lot of mental health issues. Now, how do we even handle such big populations? So these are different models that in Sri Lanka we are trying out, where we are getting communities to support the elderly. For instance, this is a little project we carried out in Sri Lanka where we used elder societies, younger elders to support older elders. And they help people with dementia in the community itself by visiting them, supporting them, helping to care for them. As you know, in the rural areas, and supporting their care, which has to be done in a very different way from what or how it will be done in our Western societies, because psychiatrists will never be able, or there will never be enough psychiatrists to visit homes or support people with dementia when it comes to covering the vast populations we have. We may be able to do it in our centers of excellence where we practice, in the cities, in Karachi or Lahore, but maybe in the far off places, we have to think of other ways of supporting the mental health needs of people who are older. Now, chronic mentally ill on the streets, this is another problem that we completely ignore. And I think we need to pay some attention to this too. Screening for the homeless. Many of them are relegated to being on the streets, begging because of mental illness. They don't have a choice, but because they are mentally ill and they don't get the treatment that they deserve, they end up as mentally ill people on the streets. We need to think of how we can reach out to them by using the communities around them and find a place for them eventually to be treated. Now, how do we think of developing services? How can we develop a service in the community? And this is a model that we have been promoting in Sri Lanka. And I think it is a very practical model, a simple model, which can perhaps be replicated in all our regions. Now, this we replicate in what we call our smallest health units. That is, we go down to our districts, and in our districts, we have what we call MOH area, Medical Officer of Health areas, small areas where we have midwives and other basic doctors practicing. And there we look at, in these small communities, the patient. And as you know, the main person who gives care to the patient is the carer. And the carer too has to be supported in our mental health module. We cannot just, in terms of community mental health, only look at the patient. We have to think of the struggles of the carer and support the carer too to do their best for the patient as well as look after themselves. So this carer is important in our community health approaches as much as the patient, because they are the first contact and they contribute mostly to the well-being of the patient, taking the patient to the hospital, making sure that they take medicines. So we know that when it comes to TB treatment, we have the DOTS model where we promote that somebody supervises the treatment of TB. Similarly, we know that in our parts of the world, often we get the carer to supervise the treatment of the patient. So this is very crucial to preventing relapse, to prevent and making sure that the patient does not fall through the gap, that they don't escape through the net, and they are brought back to the service when they fall out. So the patient and the carer have to both be the core of our focus in all our community care approaches. And then we have the health sector, and we link the patient and the carer to the closest health service where there may not be a psychiatrist, but a general practitioner or what we call a medical officer of mental health. So they may have very little training in psychiatry, but they may know, or they will have a 6 months training most of the time on the mental health drugs. And the GPs too, I will talk about it later. We are focusing in our undergraduate curriculum to train all our doctors in psychiatry so that they all will have a basic knowledge of all the mental health problems, their treatment, and their follow-up. So they will be the first contact to the patient and the carer, and they can always approach the patient and the carer. And they have links to the psychiatrist who, if necessary, will have direct contact with the patient and the carer through the clinic, because it's unlikely that the psychiatrist can directly go to the patient, but if necessary, the patient and the carer can come and meet the psychiatrist, but rarely in resource enabled circumstances, the psychiatrist may be able to visit the patient and the carer. Now, even the doctor and the medical officer mental health, they may not be designated only for mental health. They may be in the nearest hospital. They may be treating other disorders. They will be the general practitioners or the family practitioners looking after families. So they liaise with the psychiatrist. But we also promote a nurse or a field officer. Now, I know I think Pakistan and Bangladesh, we have had ASHA workers. And they perhaps also can fill this gap by sometimes visiting these families, making sure that they are taking the medicine, supporting the carers, making sure that they are brought to the hospital, making contact when they have a relapse to the nearest health facility. And in fact, they can directly contact the psychiatrist as well when necessary to support this person in the community. So we try to manage the person without coming into hospital as much as possible in the community in all our regions. In the smallest health administrative structure, which is the medical officer of health unit, where perhaps there will be anything between 10,000 to maybe 50,000 people in that unit. Now we know that the government services or the public service by itself cannot provide all the service. So obviously, we need to think of private healthcare, the social services departments. There are other NGOs and care homes which do provide services. So we need to get the link up with these institutions, and both the psychiatrist has to liaise with the patient, but also have public-private partnerships. As we all know, it's something that is a win-win situation for everybody. We need the help of the social services and the private hospitals and the private care services, which the patient too can access when necessary. And the psychiatrist will be giving input here. And also the nurse as well as the field officer too will have to, which may be a social worker, it may be a community worker, it may be anybody that we may be able to get in, who will be able to work with the social services and the NGO care homes as necessary to support the patient and the care. So this is, I believe, a very practical model that we need to try to implement in all our smallest health regions whenever possible. And this perhaps is the success of our Sri Lankan mental health delivery system. So we need to build small teams in these mental health units. And for every team, we need a medical officer mental health, someone who will support. This is our ideal Sri Lankan mental health team that we look at, where we have a medical officer mental health, as I said, a person with maybe 6 months of training. But we also went on to develop a diploma program, which again was highly commended by the World Health Organization, where we had doctors with 1 year of training in psychiatry who were able to man some of the peripheral districts where there was no psychiatrist, where they were able to give leadership. And we also trained community mental health nurses. We are still in the process. We don't have enough of any of these officers, but we are trying to train many more of these people, medical officers of mental health and community mental health nurses. And after the tsunami, we were also able to get in some district what we call community support officers, where we trained people after ordinary levels and advanced level who visited homes and supported people in their rural settings, in their villages. And the psychiatrist was the lead who supervised many of these teams in the district. And I know even in Pakistan, the policy advocates a district psychiatrist who will supervise the district mental health and the psychiatric care in the districts, every district of Pakistan. So I think we need to develop smaller teams which work under the district psychiatrist to reach out to the community And we need to think of these three categories of work: a doctor with basic training, a nurse who can also work in psychiatry, and maybe support officers who may not have any medical training, but who can be befrienders. As you know, I think in Pakistan, you have a lot of befrienders again, whom were developed in some of the areas where there was a lot of trauma following disasters. And I think they were able to support those affected by disasters in the past and even now. So we need to think of a sustainable system. And that is why I'm promoting a separate mental health team, because in many developing countries, sometimes the West tries to impose certain models. And we too think that sometimes faith healers can be integrated. They can be integrated into some of our practices, but you know, there are pitfalls. It's not a sustainable service because faith healers have a different agenda. They have their own economic agenda. They have their own other community agendas. They have their political agendas. So they may not work for the well-being of the patient as much as the health team. And even volunteers can be difficult. Sometimes it's good, but eventually in our parts of the world, if you're not paying them anything, how much can they do? You know, because money is an important factor. They need day-to-day survival. They need to work to live. So you cannot depend on volunteers totally. So we have to have designated paid mental health teams that are supported by the government within the government sector, who can work in some way in the designated smallest health administrative structure, and maybe use the existing primary care infrastructure where we have rural hospitals, rural clinics, to also provide the mental health care to the patients and those needing mental health support. So this is our program where we use community support services, which is only now existent in the northern province of Sri Lanka. We have 9 provinces. We are still struggling to establish this cadre in the other parts of the country. But this we established 10 years back, and they are now part of the northern mental health sector. And they are school leavers who have been trained, and they take community leadership roles. They visit homes, they bring patients to the hospitals, they support the elderly in their homes. They are the first contact. So they work with the doctors in the hospital. They bring the news to the doctors, and this is a social worker, this is the medical officer, mental health seated here, and this is me, and these are the people who have been trained. And this was in a rural district called Mana, and they were able, and they still continue to be the main link. Even if there is no psychiatrist, they are able to bring the people to the doctor, and they are able to make sure that they get the minimum mental health care that is needed. So if we are to provide a service even without psychiatrists, we need to have all doctors to be trained adequately in psychiatry. And this is where Sri Lanka, we have been very successful in strengthening our psychiatry in the undergraduate curriculum. So all medical schools in Sri Lanka come under what is called the University Grants Commission. And by statute, they have to sit a common exam in psychiatry for their final exam. It is a final year subject where they have to be trained in a professorial unit for minimum of 8 weeks in psychiatry. And psychiatry is tested as a final year subject with medicine, surgery, pediatrics, and obstetrics. And it is the final year subject. So all medical students will have what we call a long case, where they will assess a psychiatric patient completely and discuss, like we do in our exams, the diagnosis based on the psychopathology and the symptoms they have elicited, and they will come to a differential diagnosis and describe the management, including the pharmacological, psychological, and social management of this patient at the final exam. And if this management discussion is not adequate, it's a common exam which we all supervise and we all get involved in, you will fail the final MBBS. So you have to pass psychiatry to pass the final MBBS, and this is a separate subject that we have brought in. And it has worked very well because all our doctors now are competent wherever they are as family practitioners to be able to identify, to detect depression, to diagnose schizophrenia and refer as necessary. They may not be so confident, but they know that they cannot stop antipsychotics, that they have to be continued. They can monitor the side effects. They can do the lithium monitoring. They can monitor clozapine in the community. So the psychiatrist doesn't have to see them weekly or bring the WBCDC. All these can be monitored in the community because all our doctors are now trained in psychiatry. And this we have been doing for the last 10 years, and come another 10 years, we will be very happy because most doctors, the young doctors, will be able to manage psychiatry, at least when we refer them back in the community as doctors. So I would like to have some more discussion on this, and I think we need to have a strategy, a national policy that is practical and pragmatic. We know that, for instance, India, they have developed a mental health act which is challenged by even the psychiatrists because some of these are not practical. It is lauded by some of the Western world, but it is not something that can really be practical to the people on the ground. So we have to develop a system that is practical. And this is where I even question the mental health gap intervention, whether that is really practical in our system without having dedicated personnel who can implement the community approach to mental health that is proposed. And I don't know, in Sri Lanka, we have not, I must say, embraced the mental health gap intervention, and we don't use that manual in our practice at all. And I'm not sure about the situation in Pakistan, and I'm also now sort of in my thinking that we should collaborate together and think of working together on certain models, and even sometimes challenge the image gap approach of WHO if it is not practical and feasible for our parts of the world. Say if you and we are not using it, then I don't think they should invest too much on this, and they should develop something that is more practical and pragmatic to our parts of the world. So the training, though, is important, and I think the MHCAP curriculum gives a lot of co-curricula which can be used for training personnel, but we have to have identified personnel. Just training non-specific people is not going to help us. We need to train people who will work with the psychiatrists in providing this care, and we have to develop unique models which suit the needs of every region. And we cannot just stop planning for now. We need to plan for the future for the next 10 years, for the next 20 years, because once it's going to take us a long time in our parts of the world, getting the funding, training the people will take us 5 to 10 years. And we have to plan for the future. And I think we are already too late when it comes to planning and implementing some of the things that we have to do. I know it is very challenging as psychiatrists. We are very few, we are stretched, but I think we have to provide the leadership, and we have to think beyond just the psychiatric curricula to think about developing the services. And I know many of the senior leaders in Pakistan have done so much, and I do respect them for the amount of service that they have developed in the region. I have had the wonderful opportunity to join the Pakistan Psychiatric Society in many of their conferences in Lahore, in Karachi, and also the SAARC conferences. And I'm so happy that I can have this discussion with you, and I know that you will have many more thoughts and understanding on this. So I will open it up for discussion, and I will end by thanking you, but I will like Prof Afridi and the others to discuss some of the issues I have raised, and also maybe bring out alternative views on what you think should be done in terms of the challenges that we have to face And the opportunities are also numerous. Unlike in the West, we have the families, we have the communities who are supportive, who want to help, and all our patients live in the context of the community and a supportive family. And this is the resource we have, which we can use maximally in helping our people. So thank you again for inviting me to deliver this lecture. And I will stop now and invite you for discussion, reminding us of the close relationship and the close camaraderie and the friendship we have with Pakistan and Sri Lanka through cricket, which we all enjoy, which makes us all happy and improves our mental health. Thank you.
Thank you, Dr. Shehan. It was very detailed, thorough presentation and statistically oriented. Now I would like to request our participants, if they have any query, they may share their query in the chat box, or they may directly ask from Dr. Shehan by requesting unmuting. We have some guests from Pakistan as well, current President of Pakistan Psychiatric Society, Imtiaz Dogar, and also before. So we are actually waiting for any query if participants have. Otherwise, Professor Iqbal Afridi would like to share his thoughts regarding the presentation, sir.
First of all, I am very thankful to you, Professor Shehan, for such a thought-provoking presentation. And I think Pakistan and India, Bangladesh and Sri Lanka, they share these social cultural ways. So therefore, we can have such talks again and again, and we should also have a combined research program so that we can understand what is the prevalence of the diseases and how we can help each other. Regarding the number of psychiatrists in Pakistan you discussed, we have, I was just the recent past president of Pakistan Psychiatric Society, and our current president, Dogar, is also there. So we have around 600 psychiatrists in Pakistan. But the number regarding the clinical psychologists, social worker, and psychiatric nurses is still not available. But let me tell you that around 1,800 psychiatrists from Pakistan are serving in UK and America. So that means there are more psychiatrists in these two countries as compared to our own country. But as I just knew that 150 psychiatrists are there in Sri Lanka for 20 million population. So we have around 600 population. So that means the ratio is almost the same. So thank you very much for your enlightening presentation. And I remember that while you arranged the SAARC Federation conference at Sri Lanka, you have invited very renowned speakers. And I have the privilege to listen to them and share my own presentation on the investing in mental health. And I remember your great hospitality. Thank you so much.
Thank you.
Now I request Professor Dogar, who, if he is around, to give his comments, the president of Pakistan Psychiatric Society. And let me also tell you that on one line where around 50 doctors are here. So this means the participants which are visible are more than that which are attending this program. So now, Professor Dogar.
Thank you, Professor Afridi. Thank you very much. और जैसे आप बता रहे हैं, many people who are in groups, they are joining. So there are more than 50 they are appearing, and we are very thankful to Professor Shehan William, who is of course Secretary of SAARC Psychiatric Federation, as well as immediate past president of Sri Lankan College of Psychiatrists, and he has very comprehensively elaborated some of the aspects, and there are challenges and there are opportunities. I think again working on, and we have been working, focusing on this very community mental health is the need of the time as well as need of the region. And of course, he has highlighted, I would like to compliment further, like working on medical students. We teach them psychiatry like in final year, and it's 1/4 of their B paper medicine. Some of the aspects they are being assessed in more in MCQs and SCQs, but sometimes there is a short case. Regarding long case, he has guided us. Of course, we'll be insisting our universities and our medical system that that shall be component, so that medical student can pay more focus. But then in 2 or 3 of the provinces out of 5, we have got a separate subject in 3rd year medical students, that is behavioral sciences, where we are able to teach them some of the psychological aspects related to psychiatry, their communication skills, their ethics, and other aspects we will try to cover. And in 3rd year, we have exams related to them. And then going on towards general physicians training, of course, there used to be some of the trainings with WHO support, and Pakistan Psychiatric Society is presently having a plan, and we have started this at our own level to train the different our general physician colleagues. It's a 2-day extensive course on 8 priority disorders enlisted in WHO mental health gap. That is what we are doing. And of course, that's the need of the time. And we need to focus and teach them, particularly related to our area's problem, like addiction, we are focused. And then Pakistan Psychiatric Society in previous regime under Professor Iqbal Afridi, as you have mentioned, we have developed special interest groups as well. And we have divided our people according to their interest and according to their expertise. Of course, forensic is our different need, and then rest of the world, of course, and then it's geriatrics, drug dependence, all the areas we have divided. And of course, child psychiatry is one of the neglected. We have got very few, like 4 or 5 qualified child psychiatrists. And we are working in close collaboration with our friend from Qatar, Professor Bakar, who is helping us. And child psychiatry has been introduced as a second fellowship with College of Physician and Surgeon. We're going to assess people who after general psychiatry, they can opt that. And talking about further training, as you have given us the concept of team, of course, this the district psychiatrist or consultant psychiatrist working closely with those mental health workers as well as the GPs is the solution. And we need to devise some joint strategy. Although Professor Afridi mentioned it's about 600 psychiatrists and more than 3 times working outside, but those who are over here, and we can take them on board. But the population is quite higher. It's 220 million, so we require more trained people. And this community mental health is the only solution presently available. And of course, we need to, as being professors and being team leaders in different aspects, this shall be. And you have reminded us again of our role that we need to focus on this very aspect, and will be able to provide better services to masses in all the regions. And we are again very thankful, and collaborative research, as Professor Afridi has mentioned, is one of the area where we can work together, and then training aspects, and then upcoming conferences that can be of help. Let's see how the COVID goes. Inshallah, we have planned a sort of like in November, Pakistan Psychiatric Society is going to hold its annual meeting. And if things settle, then but we'll be sending you an invitation earlier, inshallah. And we hope to see some of the colleagues coming from overseas as well. Thank you very much.
Thank you.
Thank you, Dr. Dogar, for your valuable input. Now, as a part of token of appreciation, I would like to request Professor Iqbal Afridi for sharing the e-certificate, which we do with every guest speaker. Sir, we have
basically, the idea was that after COVID, we have a gap of teaching and training. So we started this program and very successfully conducted this program. So as a token of appreciation, let me present the e-certificate to our worthy speaker, Professor William Shehan.
Thank you very much. Thank you.
Let display it. Just a second. Can you see it?
Not yet.
Share.
I think it's coming on.
No, let me display it.
It's coming on.
Yeah.
Now I think it is all visible.
Oh, thank you very much. That's very nice.
Thank you very much.
Honored.
And I'm also thankful to all the participants, especially our President, Pakistan Psychiatric Society. And I think Dr. Zain is there. Is Dr. Zain is there or not? I don't think so. So with this, we will end the session. If you have still a question, So that will be displayed on. Is there any question?
No, sir.
Okay.
Not very.
So that means that the talk was very comprehensive and understandable. So there is no question. So thank you very much for your kind and your comprehensive talk.
Again, thanks to the speaker and to the organizers, Professor Iqbal Afridi and his team. We are very thankful.
Thank you, sir. Thank you.
Thank you.